The picture on the screen is for the caves at Petra. People used to live in these caves for, all through their lives. So some were born, raised up in these caves. So definitely I'm going to invite you to go to Petra if you come. Nick, have you been to Jordan?
I haven't. It's my ambition and desire.
Okay.
Yes.
And the same, Wendy. Really,
no, I haven't. I'd love to.
You should come. I've been to Petra last week, and it was amazing. I've seen it before, but I've been to one of these caves. It's really interesting, and now they're doing a very nice tents with opened ceiling. In which you can watch the stars at night. It's amazing. It's something that's breathtaking. So definitely, inshallah, we're inviting you in person, in physical, to come here in Jordan and enjoy these two really amazing two places, Wadi Rum and Petra.
Thank you very much.
We look forward to it.
Yeah. And the Dead Sea,
the Dead Sea is amazing as well.
Among the mountains. It's the Red City. Yeah. It was built by the Nabatees.
Yeah. So hopefully, Nick, you have to come really. You should come. We see each other a lot, out of Jordan, but definitely.
We're neighbors. My parents are in Cyprus, so it's a very short journey from there.
Oh, your family are from Cyprus.
Yes.
Okay, good. Which part?
The south.
The south. Okay.
Yeah, Cyprus is 40 minutes flight from Amman.
Yeah,
that's a quick swim. Sharpens the appetite.
Yeah.
My swim is longer.
Oh.
Yeah.
It's just a pond, Wendy. It's just a pond.
Yeah. Well, I heard they're going to have a new supersonic jet, 3 hours to Paris from New York.
Wow.
Yes.
Let's hope it's quieter than Concorde. We live under the flight path.
Yeah.
And there are also submarines, in which you can, go around Dubai and very low, very high speed, a few minutes to reach wherever you want.
Abir, we're close to time now.
Yeah. Suleiman. Ibrahim.
نعم دكتورة.
Can we start?
نبلش ولا نستنى شوي؟
1 minute.
Start on time.
You want 1 minute, okay.
بس السكرين في ويبينار is being recorded. هاي شو ليش طالعة؟
لأنه it has to be recorded.
Recorded.
Can you get rid of it?
لا خليها recording موجود.
هي عم تطلع على السكرين يا عبير، عم تطلع على السكرين.
ما لازم تطلع. It has to be on the screen.
دكتور ماهر احنا كل سيشن هيك بنساويها بتكون مبينة.
It is there.
مبينة وين السلايدات رح يطلعوا؟
بالنص محل بترا ما موجودة.
طيب خلص اوكي يلا.
دكتور عبير تفضلي.
تفضلي.
اوكي عندك العدد لساته مش هذا مش
100 منيح عبير كبداية.
Okay, we have to start on time. Okay. I welcome you all into this webinar, which will deal with management of menopause and osteoporosis. Dr. Fakhr Shatnawi from the Jordanian Society of Obstetricians and Gynecologists is going to join me as a moderator. This is the fourth webinar for the joint activity between the Jordanian Society of Obstetricians and Gynecology and the RCOG Jordan Chapter Committee. We have with us today 3 best international speakers to talk about menopause and osteoporosis. Nick Panay from UK, Wendy Wolfman from Canada, and Alia Khan also from Canada, and Dr. Abir Annab from Jordan. So there will be a 25 minutes talk followed by 5 minutes discussion. You can address your questions at the Q&A button. Our first speaker will be Dr. Nick Panay from UK, and he will talk about optimizing HRT and alternatives, past mistakes, and future directions. Very interesting topic. Okay, he's the president-elect of the International Menopause Society. He's the director of the International Center for Hormone Health. He practices at Queen Charlotte, Chelsea, and Westminster hospitals, as well as Imperial College London. Please, Dr. Banay.
Thank you very much for that very generous introduction. I'm sorry I can't be with you in person. Thank you to the Jordanian Obstetrics and Gynecology Society for inviting me to speak. As our chairperson said, I'm going to be talking about optimizing HRT and alternatives and looking at past mistakes and talking about future directions. These are my declarations of interest. So why is this an important issue? Well, it's important because we're living in an aging society, and many of these people who are aging live with a declining quality of life and health. And I believe that many women are suffering in silence and are being denied HRT because of general fear about this particular type of medication. So let's talk a little bit about the menopause, because it is characterized by a variety of symptoms and conditions associated with estrogen deficiency. We know that there is a prevalence of flushing, sweating, and sleep disorders and mood changes, which occurs as the perimenopause starts between the ages typically of 40 to 50. Other symptoms such as urogenital atrophy and dyspareunia then occur from mid to late 50s onwards. And then particularly in 60s, but sometimes even earlier, we have problems such as osteoporosis, atherosclerosis, and also coronary artery disease. The prevalence of vasomotor symptoms by years from and to the menopause transition was determined in this meta-analysis of 6 individual studies of women in the menopause transition. The percentage of women experiencing symptoms began to increase in the years before menopause, peaked at approximately 1 year after the period, and did not return to premenopausal levels until about 8 years after menstruation ceased. So in the past, perhaps we used to say to our patients, oh, 2 or 3 years and the symptoms will be over. But of course, we now know that the symptoms last for much longer, and therefore it's very important that we address these effectively. And we know that vasomotor symptoms are early precursors of hidden risk. For instance, they can predispose to cardiovascular events, osteoporosis-related fractures, and cognitive decline. The presence, in fact, of vasomotor and other symptoms of menopause is associated with a significantly greater risk of cardiovascular disease. Statistically, there's a 34% higher risk of coronary heart disease, a 30% higher risk of stroke, and a 48% higher risk of other cardiovascular diseases. In this recent enormous study of more than 1.2 million Korean women, later menarche and early menopause and shorter reproductive span were all associated with an increased risk of fracture. The study findings suggest that higher fracture risk is associated with a shorter lifetime exposure to endogenous estrogen. This recently published large nested case cohort study from Taiwan looked at the impact of HRT on fracture risk in terms of timing, dosage, and adherence. The study included more than 26,000 women over the age of 45. They found that current use of HRT had a protective effect against fractures, and that this effect increased with application of higher cumulative daily doses of hormone therapy and also greater adherence to HRT. The past use of estrogen-containing HRT also had a similar benefit, which indicates that the benefits of HRT are not necessarily completely lost when discontinuing hormone therapy. So what were the problems with the Women's Health Initiative study, which is a study that many people are familiar with and led to discontinuation of hormone therapy in over 50% of women? Well, the timing and dose of HRT matters, as well as the regimen. In terms of the WHI, it was a wrong population. It was an elderly population with an average age of 63. A significant proportion were obese and hypertensive, and it was a wrong type of HRT regimen, in my view. It was a wrong progestogen because MPA increased insulin resistance, reduced arterial compliance, and increased breast epithelial cell proliferation. Also, the dose, 0.625 milligrams of conjugated equine estrogens, was too high for the older age groups, particularly the women in their 60s and 70s. These are the data looking at the coronary heart disease risk, and you can see that the excess number of cardiovascular cases was in fact only present in the oldest age group. Estrogen may be ineffective or trigger events in the presence of existing advanced lesions, such as those found in older women. However, a window of opportunity seems to exist to reduce cardiovascular risk in younger women, as you can see here. So let's talk a little bit about this window of opportunity. A recent publication in The Lancet, this was a position statement from a group of eminent menopause specialists, stated that the menopause transition was a golden age to prevent cardiovascular disease. They made the point that coronary heart disease and stroke are the leading causes of death worldwide for both women and men, according to WHO estimates in 2019. The menopause transition is a time of increasing cardiovascular disease, and women are more vulnerable to cardiovascular disease risks due to high blood pressure, which is very common after the age of 50. HRT, initiated in women under 60 years or less than 10 years from the menopause, is currently the only intervention that reduces the risk of cardiovascular disease and diabetes in otherwise healthy middle-aged women. These are data from a meta-analysis from the Cochrane Group in the UK of cardiovascular disease risk with HRT. Starting HRT less than 10 years after menopause reduced the risk of all-cause mortality and coronary heart disease compared to placebo or no treatment. The relative risk was 0.7 for all-cause mortality and 0.52 for coronary heart disease, and this represents a 48% reduction in risk. There was a non-significant increased risk in stroke and a small increased risk in VTE, which is expected with oral hormone therapy preparations. In this prospective Dutch study, nearly 2,700 women were issued with questionnaires at the age of 68 to 70 and followed up 20 years later. 928 of these women lived to the age of 90. And those that started HRT before the age of 50 had a significantly greater chance of living to the age of 90 compared to those starting at 50 years or beyond. So this is really summarized very nicely in the International Menopause Society recommendations on women's midlife health. The window of opportunity is basically that there is evidence that estrogen therapy may be cardioprotective if started around the time of the menopause transition, and this is referred to as the window of opportunity or timing hypothesis, but may be harmful if started more than 10 years after menopause. And these data are supported by the WHI study, NICE UK, and the Cochrane analysis, and in fact is supported by all society guidelines. So how can we reduce problems by modifying the HRT regimen? And first of all, let's talk about androgenic versus non-androgenic progestogens or progesterone and breast risk. And going back to the IMS recommendations, one of the key statements is that the increased risk of breast cancer is primarily associated with the addition of progestogen to estrogen therapy and related to the duration of usage. Possibly due to the pro-apoptotic effect of natural progesterone and dydrogesterone, there was no significant increase in risk with these combinations in both the E3N French cohort study and in the Finnish cohort trials, whereas there was a small increase in risk with other standard HRT combinations, as seen here in the E3 cohort and in the Finnish cohort, using MPA, NETA, and other progestogens. The conclusions from this extensive review of 143 studies, where 19 were deemed to be suitable, was that estrogens combined with micronized progesterone do not increase breast cancer risk for up to 5 years. There is, however, some limited evidence that estrogens with oral micronized progesterone for more than 5 years is associated with an increased breast cancer risk. Counseling on combined hormone therapy should cover breast cancer risk factors regardless of the progestogen chosen and other risk factors which are involved. Even in the WHI study, despite the use of medroxyprogesterone acetate, which one could argue was the worst case scenario, there was no increase in breast cancer mortality. At 20-year follow-up, women using conjugated equine estrogens alone had a lower risk of breast cancer. Women using conjugated equine estrogens with MPA had a slightly higher risk of breast cancer, but no increase in breast cancer mortality. So what about VTE risk? Once again, we look at non-androgenic progestogens and progesterone and VTE risk on this occasion. Well, androgenic progestogens may modulate the increased risk conferred by oral estrogen. For instance, they're thought to cause venous pooling and dilation. And there appears to be a lower risk of VTE in progesterone and dydrogesterone HRT, even with oral estrogen administration. So the odds ratio in the E3N French study was 0.9, and the odds ratio in the ESTER study, the data which I'll show in greater detail in a moment, was 0.7 for progesterone, 0.9 for progesterone-derived progestogens, such as dydrogesterone. I'll just demonstrate this for you in this next slide. So ESTER was a case control study of 271 consecutive VTE cases versus 610 controls. And in this study, HRT with micronized progesterone or pregnane-derived progestogens did not increase the risk of VTE, but the increased risk was seen with oral estrogen and also with the norpregnane, more androgenic type of progestogens. These are data from two large nested case control trials in the UK. They looked at more than 80,000 women with VTE, and these were matched by age to more than 391,000 controls. Of those on oral conjugated equine estrogens with MPA, they had the higher risk for VTE, but those with estradiol and dydrogesterone of the oral preparations had the lowest risk. Transdermal preparations were not associated with an increased risk. So what about the advantages of lowering the estrogen dosage? What is the advantage there? Of course, we have to balance treatment in terms of the severity of symptoms versus the risks associated. But if you have somebody that doesn't have particularly severe symptoms, they don't necessarily need to start on a high dose preparation. These are data from the nurses study, observational study in the United States by Frank Grosdien. And you can see for those women on the lowest dose of conjugated equine estrogens, 0.3, there wasn't a significant increased risk of stroke. But there was a dose response effect in terms of the stroke risk, and it was highest for those on the 1.25 milligram dose of conjugated equine estrogens. The risk of VTE appears to be decreased by lowering the dose. As you can see here, there is a dose response effect, but even at the 0.3 milligram conjugated equine estrogen dosage, there does seem to be an increased risk with oral estrogen. Having said that, we are actually investigating an even lower dose of estrogen in the optimized trial. I'm performing this study with my colleagues Sophia Tilianis and John Stevenson at the Royal Brompton Hospital, and we're looking at 0.5 milligram dose of oral estrogen versus a 25 microgram transdermal patch. And we're looking at thrombin generation as a surrogate marker for VTE risk. And we're hoping that when you use the very lowest dose of oral estrogen, then you don't increase the risk of thrombosis at all, which is the case with transdermal estrogen. So given all of that, I think we should be working towards the ideal study. And there have been a couple of studies that could be regarded as pilot studies, if you like, for what would be the perfect study using the information that we have now, rather than the information that they had when WHI was designed. So the KEEPS study was a randomized controlled trial of 729 healthy postmenopausal women aged 42 to 59. They were studied for 48 months, and these women, unlike WHI, were less than 3 years postmenopause. The interventions were a lower dose of conjugated equine estrogens and WHI of 0.45 milligrams, or 50 micrograms transdermal estradiol, and metabolically neutral progesterone was given with micronized progesterone. Because this was a much smaller number of women than WHI, they had to look at surrogate outcome measures, and they looked at ultrasound carotid artery intermedia thickness and the CT coronary calcium scores. And I just want to show you a couple of the data slides from this study. So this shows the changes in arterial imaging of the carotid intermedia thickness, and you can see that there was no difference between the three groups, the oral conjugated equine estrogens, transdermal estradiol, or the blue placebo group. And that's probably because the study was too short and this was too healthy a population to see differentiation between the groups. But it's reassuring that there was no adverse effect from being on hormone therapy. Also, there were no serious adverse events seen in terms of cancer risks, endometrial problems, arterial and venous problems, and deaths. The ELITE trial, I think, is one of the key studies that we should use in terms of designing future trials, in that it showed very compelling evidence for the window of opportunity hypothesis. So this was a study conducted by Howard Hodis and colleagues in California of 643 postmenopausal women studied for 5 years, and included two groups, one group less than 6 years after the menopause transition, and one group more than 10 years after the menopause transition. And the women were randomized to estradiol 1 milligram or placebo. And for those women that were not hysterectomized, they received vaginal progesterone gel, 4% for 10 days per month. Once again, they looked at the surrogate outcome measure, which is the carotid artery intermedia thickness, which was checked every 6 months. And what was found was that there was a significant reduction in the carotid intermedia thickness progression of HRT users in the early postmenopausal group, but not in the late postmenopausal group. The study was too small to look at major clinical events. And here you can see there's no difference between the curves in the late postmenopausal group between placebo and estradiol, but in the early postmenopausal group, you see that there is less progression in the estradiol group than there is in the placebo group. So the good design aspects of KEEPS and ELITE was that they looked at women in a younger menopause age group, more appropriate to the type of women that we see in our clinics. They were using lower doses of estradiol, and they were using less androgenic endometrial protection with micronized progesterone. However, the limitations of the design was that these were small populations, so less than 1,000 in each study. They were of limited duration, less than 5 years, and they were looking at surrogate outcome measures. So in my view, the time has come for the definitive randomized hormone therapy trial to be performed in the correct women for the correct indication with the correct preparation, given current knowledge. The study population would be no more than 5 years from the menopause transition and would be randomized to receive a transdermal estrogen with natural progesterone for endometrial protection and compared to placebo, at least for the first 5 years. Clearly, the problem is that the event rate is very low in younger populations, so this would have to be a massive global multi-center study over a minimum of 10 years if we were to have meaningful results on outcomes such as breast cancer and coronary heart disease. And of course, funding is the main barrier of doing such a study. So who knows if we will see it, but we'll certainly work towards having it as part of our research and development program in hormone therapy in the future. So what about practical prescribing in the last 5 minutes? Because ultimately, that's all very well hearing the theory, but what do I do with my patients? And hopefully you can transfer some of this information into how you manage yours. Well, I tend to favor replacing like with like, body identical or body similar types of hormone therapy preparations. So in terms of transdermal estradiol, you can use patches, you can use a gel. There's even now a spray called Lenzetto in some countries. My preference is to combine that with a body identical type of progesterone like utrogestan, which can be used at 100 milligrams continuously or 200 milligrams sequentially. If women have progestogenic side effects, then the progesterone can be inserted vaginally, although in the UK, certainly, it is off-label to insert it vaginally. Quinone or cyclogest are other possible ways of administering progesterone vaginally. There is a body-identical combined oral regimen now called Bijuva in the States. It'll be Bijuv in Europe, which is 1 milligram of estradiol and 100 milligrams of progesterone. But I think the body-similar combined oral regimens of the Femoston range is also a very useful range, very well tolerated, and has a very similar metabolic effect to natural progesterone. In terms of androgenic preparations, and I believe that testosterone is a female hormone, and particularly in women who've had the ovaries removed, we should be talking to them about testosterone as well as estrogen replacement. The problem is the lack of licensed products globally, but what we're aiming to do is replace a physiological amount of testosterone, which is represented by a dose of 5 milligrams per day, which is about 1/10 of the male dose. So you can ask the women to use a 1/10 of the testosterone gel dosage. And typically, you know, if it's a Testogel sachet, each sachet is made to last for about 10 days. Alternatively, the Tostran 2% gel can be applied on an alternate day basis. Testosterone implants are available, but they're they're unlicensed, in fact, for the indication. Now they used to be licensed. They do deliver a supraphysiological dosage, so I recommend that these are divided in half rather than using the 100. I would recommend 50 milligrams. Androfem, testosterone cream, is actually licensed in Australia now, and this is a cream where, again, you deliver 5 milligrams per day topically by spreading the cream, usually on the lower abdomen or the buttock area. And intrarosal prasterone is a vaginal preparation licensed for vulvovaginal atrophy symptoms, although there are some data that can benefit sexuality as well. And this qualitatively seems to give a little additional benefit over estrogen alone, but I'm sure our next speakers will have views on that in terms of whether it is more beneficial than just using an estrogen alone vaginal preparation. In terms of alternatives, so particularly for those women who have suffered with malignancy, what can we offer them? Well, clonidine has been around a long time. I don't find it particularly effective. I think venlafaxine is quite effective and helps with mood, but there can be nausea to begin with. So start with a low dose, such as 37.5 milligrams, and then double up. Gabapentin can also be quite useful. Again, start with a low dose because it can cause drowsiness. Start with 300 milligrams at bedtime. It can help with sleep. Oxybutynin is showing some promise, and we're planning a randomized trial of this in the UK. And the neurokinin receptor antagonists, which a couple of them are now moving to phase 3 clinical trials, are showing great promise. And I'm going to show you some data from one of our phase 2 clinical trials in a moment. In terms of complementary therapies, the more evidence-based ones are the isoflavones, such as Promensil or Femerel, which is derived from red clover and soy. There is a product called Femal, which is derived from pollen extract, and that does have some randomized controlled trial data. And black cohosh is a possibility, but do watch out for liver toxicity. We have to be very careful about using appropriate quality control preparations. Elinzanetant is a neurokinin receptor antagonist, which we have trialed recently in a phase 2 clinical trial and showed a significant improvement at these 2 doses over placebo. And if you look at the data overall, with most of the neurokinin receptor antagonists, there appears to be around a 70% reduction in symptoms as opposed to around a 50% reduction with the other alternatives to HRT. So this could be a true alternative to hormone therapy, and very few side effects, but you do have to watch the liver function because some people do have abnormal LFTs when using these preparations. So finally, I'd just like to encourage you to look at our free educational program administered by the International Menopause Society called IMPART. And if you register for this, and after completion of the level 1 modules, you will get a certificate of completion and a complimentary introductory membership of IMS for 1 year. And of course, we would like you to join for a lifetime. So I'd like to thank you very much for your attention, and I'll be very happy to take any questions that you have.
Thank you very much, Nick, for this really excellent presentation that covered all the important aspects of HRT and alternatives. I don't see any questions and answers in the button in front of me, but I have some questions for you. If a lady like around of the age of 80 presents with hot flushes in which you don't have an explanation for it, it's not a side effect of medication, we have ruled out cancer, and there is nothing really that can explain her hot flushes except that this is a hormonal thing. What would be your advice for such an old lady? How to manage her hot flushes? She can't sleep at night, and all the investigations that was done did not give us a clue of her new onset hot flushes.
Yes, I mean, I think what you're asking me is whether I would give her hormone therapy. I would talk to her about alternatives, lifestyle, diet, exercise, minimizing alcohol, avoiding smoking, all those sort of things. And I'd talk to her about complementary therapies, some of which I've outlined in my presentation. But if her symptoms are distressing, then I think a short trial of HRT would be a test as well as a treatment of whether her symptoms respond to it. I would aim to use a low-dose preparation, and I would deliver it through the skin. So for instance, with a patch, I would perhaps start with a 25 microgram patch or even lower, ask her to cut the patch in half initially and start with a 12.5 microgram patch. And for endometrial protection, I would recommend micronized progesterone, which metabolically is the most friendly of the progesterone and progestogen products that we have. And assess how she responds to that. But I can tell you that my oldest patient on HRT is in her 90s now, and she would kill me if I took her off it. So I don't think we necessarily need to deny hormone therapy to an older age group, but we have to be very cautious how we give it. And I think it's really about keeping the dose as low as possible.
Yeah, we have a question from Dr. Murad. What is the dose of testosterone and for how long to be used in postmenopausal age group?
So the dose of testosterone is 1/10 of the male dose. So that typically represents 5 milligrams of testosterone per day at the 1% formulation. In terms of the duration of use, you make the same judgment as you would for any other hormone therapy regimen. So the guidance from the menopause societies now is that we don't put arbitrary limits on duration of use of HRT, but there should be at least an annual reevaluation of pros and cons. And that applies to testosterone as well as estrogen. We have a fabulous consensus statement published by the International Menopause Society, led by Professor Susan Davis, who did an extensive meta-analysis in her unit of over 8,000 women in randomized trials of testosterone, which showed that as long as you stick to female physiological doses of testosterone, there aren't any major adverse effects as far as we can see. But if an excessive amount is used, potentially that can lead to some excess hair growth and acne, and so the dose should be moderated. And we would recommend that the levels are checked at least a couple of times a year to make sure that the dose is not excessive for that individual. But I've never had anyone come back with a beard or a moustache.
Okay. Everybody is doing laser nowadays. Another question, please. would you recommend starting HRT in cases of diabetes, hypertension, and obesity, and they're complaining of hot flushes? And what will be your, favorite way of route of administration of HRT for these ladies?
So cardiometabolic risk is not necessarily a contraindication to using HRT. And in fact, when used cautiously, it's an indication. We know, for instance, that insulin resistance and diabetes can be benefited through the use of appropriate hormone therapy. But we have to be cautious again in terms of dosage, starting at a relatively low dose. In terms of the route of administration, again, my preference would be transdermal estrogen, so it doesn't have a prothrombotic effect. And I would recommend that micronized progesterone or dydrogesterone are used rather than androgenic progestogens, again, so that we don't exacerbate a prothrombotic effect. But as long as we use an appropriate dose and route of administration, then hypertension does not usually get worse. And diabetes and obesity actually seem to improve with the appropriate preparation. But as I say, we just have to be cautious about the dosage.
Yeah. There's a question about what are the absolute contraindications of using HRT?
Well, my old boss, John Studd, always used to say, because somebody doesn't want it or they're male and so they don't need it. But you could argue that men need it as well in some ways. But the genuine contraindications really are the hormone receptor positive malignancies and venous thromboembolism, where you have a particularly high risk case. In terms of hormone receptor positive malignancies, it's not necessary. I mean, certainly as far as the summary of product characteristics is concerned, it is an absolute contraindication. But in terms of our clinics, where we see women with breast cancer, with uterine cancer, etc., sometimes in those cases we do prescribe hormone therapy cautiously because they've tried all the alternatives and they haven't had adequate relief of their symptoms and their quality of life is really suffering. And if you actually break down the data, for instance, with endometrial cancer, stage 1 and 2, there doesn't appear to be an increased risk of recurrence. In women with hormone receptor negative breast cancer, that shouldn't increase their risk of recurrence of their hormone receptor negative cancer. If we're giving it in women with hormone receptor positive breast cancer, of course, this is very exceptional, but we would want them to be on tamoxifen that would block the estrogen receptors and then allow them to use it more safely. But we need better data at the end of the day. But those are the main contraindications. And of course, liver failure.
Abir, can I have a quick
question? Yeah, go ahead, Maher.
Nick, thank you very much. Can I just ask you, do you think as gynecologists we should promote HRT now, or we should just listen to the ladies who are requesting it? And the other quick question is, what percentage of ladies in the UK, postmenopausal ladies, are on HRT, roughly, if you have a figure? Thank you.
Yeah, I mean, I don't thank you for that. I mean, I don't really think it's a case of whether we should be promoting. I think it's a case of offering it as an option and providing the appropriate information so that women can make an informed choice. And I think that's what we should all be doing, giving women the option of a genuine option of using it. And if there are genuine symptoms that they can benefit from, then they should be using it. If they've got osteoporosis, then we know they'll benefit from it from that perspective. In terms of the percentage use, it's still low. Even in the UK, no more than 10 to 15% of women are on HRT. It used to be double that before WHI, but I don't think there is a specific figure that we're trying to achieve. I think what we're trying to achieve is appropriate prescribing where it's indicated, and in those women that we think are too high risk or don't require it because actually they're going through the menopause really well, they don't have particular symptoms, they've got good bones, then we don't give it for the sake of it.
Thank you.
Mm-hmm. Can I have a question, please, Nick? A question about the last thing about HRT and cognitive function. If you use it early, they say it might help, to postpone or decrease the incidence of Alzheimer. If you use it late, it's bad for the cognitive function. and we're not really there for the cognitive function and the HRT use. We're really in a...
No, we're not. Well, we're not there because we would need a 30-year trial in a large enough group of women to prove it conclusively. We know from the observational data that if women start HRT early, then potentially they have a reduced risk of dementia. But if they start late, for instance, in WHI, potentially it has no effect or it can make things worse. And I believe that it's the same as the window of opportunity for cardiovascular disease. So if you have cerebral vessels that are already diseased and you give a prothrombotic combination, then potentially you encourage the formation of thrombi and you lead to infarcts within the brain. If, on the other hand, you have a relatively healthy vasculature, then potentially you improve blood flow, and that improves neuronal development and neuronal health, and that can potentially have a benefit. But you know, we have to be cautious. We cannot say, if you start HRT now, you will reduce your risk of dementia in 30 years. We mustn't be saying that. But we should talk in terms of the data that we have, saying that women who are on it do appear to have better cognitive function if they have started early. But we cannot exclude for the biases, which is that healthier women may be using hormone therapy to begin with.
Yes, thank you very much. Thank you very much, Nick. We'll be moving now to
Okay. Thank you.
Thank you very much.
Great pleasure.
Looking forward to see you in person.
Thank you.
I very much look forward to it. Thank you for the invitation.
Okay, our next speaker is Wendy Wolfman, okay, from Canada. She's the director of the Menopause Clinic and the Premature Ovarian Failure Clinic at Mount Sinai Hospital in Toronto. She's the president of the Canadian Menopause Society and the first recipient of the Carol Mitchell Chair in Mature Women's Health. She recently received that Trailblazer Award from the Canadian Menopause Society, and in 2009 she received the award from the North American Menopause Society for the Practitioner of the Year Award. Dr. Wendy will be talking to us about premature ovarian insufficiency. Please, Wendy, go ahead.
Thank you very much, Dr. Anab, and thank you very much, the Jordanian Society of Obstetrics and Gynecology and the Royal College of Obstetricians and Gynecologists for inviting me to speak today. So we do have a premature ovarian insufficiency clinic, which is a multi-type of clinic at the University of Toronto. I'm a professor here, and we see many patients with this problem, and therefore I'm happy to speak on an update on premature ovarian insufficiency. So just a second. So these are my conflicts. My objectives today are to review the prevalence and etiologies of premature ovarian insufficiency, to review the symptomatic and long-term health ramifications of POI, and at the end, I hope you'll be able to formulate management options for women who have this concerning disorder. So here's your typical patient. She's a 38-year-old married lawyer. She stopped oral contraceptives 6 months ago to conceive. She had a withdrawal bleed and then did not menstruate. She suffers from hot flashes, vaginal dryness, discomfort with intercourse, irritability, and problems sleeping. And her workup shows a negative beta HCG, an FSH of 45 international units per mil, and an estradiol that's low. So what is the diagnosis here? So ESSER, or the European Society of Human Reproduction and Embryology, has given guidelines in 2016. And they define POI as a clinical syndrome with loss of ovarian activity for women under the age of 40. You can also have amenorrhea, or you should have amenorrhea or oligomenorrhea for at least 4 months with raised gonadotropins and low estradiol level. You need 2 levels of FSH over 25 on, and they should be 4 weeks apart. Some societies require an FSH of over 40, but SGR says 25. You shouldn't just make the diagnosis on one value. This is also known as primary ovarian insufficiency, since the problem arises from the ovary, or more typically in the UK, Europe, and Canada as premature ovarian insufficiency, as there may actually be intermittent ovulation in 25% of patients, or also it's known as hypergonadal hypogonadism, and it results in symptoms of decreased estrogen and infertility. The prevalence has traditionally been cited as 1% of women under the age of 40 and 5% of women who experience early menopause between the ages of 45 to 50. But more recent reviews have shown a global prevalence of actually much higher at 3.7% and 12.2% of women with early menopause. So that's really a significant number of women. We also, for easy memory, say 1 in 100 women will be menopausal by the age of 40, 1 in 1,000 by the age of 30, and 1 in 10,000 under the age of 20. The pathogenesis relates to the loss of ovarian follicles. Women are born with 700,000 oocytes in primordial follicles at birth, and there are 400,000 at puberty. There are 400 to 500 ovulations in women's reproductive life, and there are 1,000 oocytes that remain at menopause, usually the most resistant ones. The fertile lifespan of any woman depends on how many she is born with, the rate of depletion over her reproductive life, active destruction of these follicles, and problems in recruitment or maturation of the follicles. And most recently, it's been postulated that there may be inadequate renewal of stem cells. The etiologies of POI are several. Actually, the most common cause is idiopathic. That is, we can't find the cause in 90%, but that is mostly, I think, because we aren't looking for all of the specific genes. And I think now that we're doing whole genome assessments, we will find many more patients that have a genetic cause. The iatrogenic causes are increasing, and I'm going to talk about that in a minute. These include chemotherapy, radiation, and the surgical causes, that is bilateral salpingo-oophorectomy, risk-reducing salpingo-oophorectomy, cystectomies typically after removal of endometriomas, and even embolization. There is more data about surgical POI than actually spontaneous POI in terms of the long-term ramifications, and they are often pooled together in terms of their ultimate outcome. But there is a difference, and women with surgical POI actually have more severe symptoms and more severe cardiovascular ramifications. The genetic causes are 10 to 13% of all etiologies. They are mostly Turner syndrome, which occurs in 1 in 2,500 women in gene frequency, and then Fragile X, which is 3% of spontaneous cases. And there are some rarer, more autosomal types of genetic causes. If you actually ask closely, 20 to 30% of women have a family history of early menopause or POI. Autoimmune causes are 5%, metabolic such as galactosemia, infectious postulated or associated with HIV, cytomegalo, zoster, mumps, and then recently toxins and environmental exposures. We know that women who smoke have an earlier menopause of about 1 to 2 years. So when we look at more closely at some of these etiologies, if a woman presents with primary amenorrhea, she has 21% chance of a genetic cause versus those who present with secondary amenorrhea, which is about 11%. And as I mentioned, the causes are most likely X chromosomal, relating to structural things such as mosaics, complete Turners, microdeletions, deletions of different arms of the chromosomes, and then 46XY, Swire type female. And then you can find mutations actually within the X located genes, and then Fragile X, which is a premutation in the FMR1 gene, and increased number of trinucleotide repeats. The carrier frequency in the population is 1 in 250, and it's very important to diagnose this carriage because there is about a 25%, as high as 25% incidence of POI in these patients. But if a patient carries this gene, they can have a son more typically who actually suffers from Fragile X syndrome. The autosomal genes are, new ones are being discovered all the time. They may affect FSH receptor, LH receptor, inhibin, and then there are actually some genetic syndromes associated with POI, such as ataxia telangiectasia, Bloom syndrome, Perot, which sometimes are also associated with some increased risk of malignancy. Moving on to iatrogenic causes, which are becoming an increasing cause of POI. This includes surgery, which is the leading cause in the US. In the past, over 200,000 bilateral salpingo-oophorectomies were performed, most done with hysterectomies, and over 30% really not totally necessary, but for fear of ovarian cancer in younger women. Chemotherapy and radiation, the risks relate to the age, the ovarian reserve of the patient, the type and dosage of radiation. 1 out of 49 women develop cancer before the age of 40, and up to 2/3 of cancer survivors develop POI. Some of the medications which are particularly toxic to the ovary include the alkylating drugs, the taxanes, and higher doses of chemo. And cyclophosphamide is a particularly bad player, often used for collagen vascular diseases. And after the age of 30, if it's administered, 2/3 of women become infertile. Radiation is actually more damaging to primordial oocytes than chemo, although higher doses administered to children may be tolerated better. As you get older, women tolerate less radiation in terms of their infertility. So moving now on to autoimmune POI, it occurs in 4% of the cases of POI, and all these types of autoimmune diseases have been associated. There are antibodies versus ovarian tissue, as well as adrenal 21-hydroxylase autoantibodies in many patients. And it's postulated that there are changes in cytokines, B and T cell function. If you catch this early, you may see early cystically enlarged ovaries. If the patient is found to have adrenal antibodies, you should refer to an endocrinologist, as this may occur prior to actually adrenal insufficiency, which is a life-threatening disease. There are some genetic polyglandular syndromes which also cause autoimmune primary ovarian insufficiency, but they are much less common. So what are the sequelae of premature ovarian insufficiency? We have symptomatic and we have other longer term issues. We have the vasomotor symptoms, sleep disturbance, mood change and depression, joint aches, vaginal dryness, sexual issues, and infertility. The longer term issues are really important. They include decreased quality of life, increased cardiovascular risk and osteoporosis, decreased mood and depression, earlier neurological problems, and even earlier death. This is a huge diagnosis for a young woman with big ramifications. So as I mentioned, we have more information about surgical POI because the sudden loss of estrogen, testosterone, and progesterone symptoms are more acute and severe. Studies, and there are many, many studies now, some of which I listed below, showed increased mortality, increased coronary heart disease and death from cardiovascular disease. And one recent very large study from the UK compared the incidence in 7 significant cardiovascular ramifications and found that the incidence was higher in surgical than spontaneous POI, both of which were higher than women who had regular menopause at the age over 40. There's also an increased risk of obesity, hyperlipidemia, insulin resistance, hypertension, autonomic and endothelial dysfunction, as well as an increased incidence of dementia, Parkinson's disease, depression, and anxiety, and even glaucoma and some eye changes. In terms of bone risk, the prevalence rate of osteoporosis is 8 to 27%, and it's felt to be due to the insufficient peak formation of bone, lack of estradiol, both on the osteoclast as well as the effects of FSH on the osteoclast, the comorbidities that occur with POI, and also underlying genetic causes that may contribute to this bone risk. It is associated with lower vertebral bone mineral density, and estrogen therapy is protective. A recent systematic review showed an increased risk for early menopause, but not POI, and it was felt that this was due to insufficient total numbers of patients within the POI studies. It is recommended to do a bone mineral density at baseline and every 5 years. The definition for low bone mass in women is different because the women don't reach their peak bone mass. So under the age of 50, it's been recommended that it's a Z score under -2. And the definition of osteoporosis by the International Osteoporosis Foundation is still -2.5. The best treatment here is estrogen replacement therapy, not bisphosphonates, as bisphosphonates stay in the bone for long periods of time. And if the woman is considering getting pregnant with an egg donation, that might be detrimental to the fetus. So just reviewing the diagnosis of POI, 90% of women present with secondary amenorrhea or oligomenorrhea. She may or may not have menopausal symptoms. About 10 to 15% of women do not. She may just be diagnosed after investigation of infertility. There's typically a family history of early menopause. There may be some multiple factors that have contributed to this, maybe previous chemo or radiation, even as a child. And she may be a smoker. 50% of women saw over 3 clinicians before they had the diagnosis made, and 70% of women were unhappy how they were told about the diagnosis. The diagnostic physical and tests include the regular height, weight, waist circumference, all the vital signs, looking for neurological signs or other stigmata of other congenital disorders, such as increased carrying angle, decreased height, heart murmur with people with Turner syndrome, autoimmune, maybe vitiligo, alopecia, thyroid examination, Tanner staging of the breast, looking for pubic hair, axillary hair, chest exam, abdominal exam, and pelvic exam to check for genitourinary syndrome of menopause. In terms of the investigations, initially pregnancy tests, prolactin, FSH on 2 samples, estradiol level, TSH, and possibly AMH. After the diagnosis, we always do a karyotype, an FMR. You can do a natural follicle count. Thyroid antibodies should be done, thyroid function tests, and anti-adrenal antibodies, as well as a baseline DEXA. And I recommend also other metabolic baseline tests as necessary. What is the best replacement? You should individualize the therapy. It depends on the patient and her compliance. Whatever she's going to take is the best therapy. So in general, our younger patients tend to prefer oral contraceptives because they don't like being different from their friends. Older women tend to get it more and they prefer hormone therapy. We would typically use higher doses than for a regular menopausal woman, such as 100 micrograms of estradiol, 2 milligrams of estrase, or 1.25 of conjugated equine estrogen, 12 days of sequential, either 300 progesterone or 10 milligrams MPA, or even a progesterone IUD. If the patient doesn't want to menstruate and you want to give a daily progesterone, actually, we don't know the optimal dose to use to prevent endometrial growth with higher estradiol doses. So if you're going to give 100 patch, you often have to give 200 milligrams daily of progesterone to cause amenorrhea. If you're going to give an oral contraceptive, and remember, 5 to 10% of these women may conceive, especially early in the diagnosis, and if they don't want to get pregnant, this may be a big surprise. So long cycle, low dose oral contraceptive is recommended, and we do not usually give a 7-day rest, because if you do that over a year, you have 3 months with no hormone. So we'll typically give 2 months of a 21-day patch with 4 days off. What is the risk of hormone therapy in this age group? It should be viewed as mandatory replacement, comparable to other endocrine LACs. The results from the Women's Health Initiative do not apply to this age group. There was no woman under the age of 50 in the Women's Health Initiative. It may be preferable to use transdermal hormone therapies and oral contraceptives, and there are some studies suggesting more benefit for bone effects, definitely for blood pressure, lipids, and possibly libido. The symptoms of GSM, I'm really going to leave to Dr. Anab, but just with higher doses of hormone therapy, that may be adequate for the vulva, but you can supplement with local therapies as well and not worry. Depression and mood, supportive counseling, recognizing the impact of involuntary infertility in young women. Many women feel old or suddenly aged. This can be life-altering and grief-inducing. Women may have psychological problems. They have an increased lifetime risk of depression, lower self-esteem, poor body image, and lower self-confidence. And therefore, providing emotional support is essential. And there are lay support groups such as the DAISY Network in the UK. What about sexual dysfunction? This is increased in POI. It should be acknowledged and individualized and really asked about. It may be multifactorial, just like any sexual dysfunction in women. Women experience fewer fantasies, less masturbation, arousal, lubrication, and increased genital pain. And this dysfunction may persist despite adequate estrogen therapy. So we recommend basic counseling, combining cognitive behavioral therapy with sexual health education, hormone therapy, systemic and local, and consider transdermal testosterone that Nick outlined or other pharmacologic treatments. So in summary of the treatments for POI, hormone therapy until average age of menopause, treat the GSM, psychological support, address the sexual dysfunction, and discuss infertility when the patient is ready. In terms of cardiovascular and metabolic risks, it's all the motherhood statements. Optimize weight, blood pressure, exercise, lipids, reduce diabetic risk, stop smoking, and Mediterranean diet. In terms of the bone, weight-bearing exercise, risk assessment, muscle strengthening, vitamin D, at least 1,000 IUs per day, especially in a country like Canada where we don't get sunshine. Calcium, preferably through diet, 1,200 milligrams per day, and smoking cessation. And I'm going to say a few words now on fertility. So what is and how do we get these women pregnant? Really, by the time a woman is diagnosed with POI, her chances of conception are much less. And women come back time and time again, or they seek multiple physicians to try and find the answer. Embryo or oocyte donation is her best chance. And really, I always talk about it takes 3 people to make a pregnancy: the sperm donor, the egg donor, and the carrier of the pregnancy. And during the pregnancy, women make epigenetic factors that impact the genetic expression of that egg. And so that child could no more be that person's child unless it was genetically related. And so I really discuss that with patients, tell them the pregnancy's the same, the delivery's same, the nursing's the same if you get an egg. The only thing is you get an egg from someone else. You have to be careful with Turner's pregnancy. You have to get cardiology input, as well as people who have received anthracycline and cardiac radiation. But the success rate with egg donation is very high. If you have time, that is, if the patient had a malignancy or she has a genetic issue that which she won't give on to the fetus, you have to be careful. You could do ovarian tissue cryopreservation, oocyte, or embryo freezing. I'm going to talk a little bit about ogonial stem cells. Stem cells are still experimental, although there have been 4 pregnancies in the literature. Some religions would not approve surrogacy or egg donation, but surrogacy is a possibility, or adoption. The older literature on improving fertility really has shown no better outcome than the 5 to 10% baseline rate. So what's been looked at? Estradiol alone and estrogen replacement prior to ovulation induction. That did have a little bit of promise, and I think there needs to be bigger trials looking at that. DHEA, although we got higher counts and ovarian volumes, was not wasn't better than control. And a Cochrane review showed it might improve the live birth rate in poor responders. Another study showed no benefit. Corticosteroids, follicular monitoring, both have not shown any improvement. Most recently, and I would refer you to this article by Rosario, and I'm not an infertility specialist. I am a general gynecologist with particular interests in menopause, but these novel techniques have been prescribed, and it's been postulated that they will raise the pregnancy rate to 18% from 5%. But they've primarily been looked at in women with reduced ovarian reserve rather than premature ovarian insufficiency. And they rely on the fact that there are 1,000 oocytes remaining at menopause, and that 50% will have persistent ovarian function, and 20% of women still may ovulate. This idea of germline stem cells is controversial, and there is more research to try and make sure that that's true. They are true in animals, and there have been pregnancies with these types of germline stem cells in mice. Mesenchymal stem cells are a promise, and they are from the bone marrow. There have been 4 pregnancies. They also have been injected into the ovary from the placenta, umbilical cord, and even menstrual blood has been injected into the ovary to activate residual primordial follicles, because these stem cells contain growth factors, and it's felt they induce the residual follicles to develop. There's also been research in activation of remaining primordial follicles via physical or chemical manipulations, and there's been 3 pregnancies there. Platelet-rich plasma, which has growth factors, has been injected as well, and there was 1 twin pregnancy, but also gonadotropins were given in that patient. We really need more studies, and the results are preliminary. So in conclusion, you should suspect premature ovarian insufficiency in young women with secondary amenorrhea who are not pregnant. You should prevent premature ovarian insufficiency by preserving ovaries at hysterectomy if possible, and not smoking. Consider GnRH during some cancer treatments, and oophoropexy if you have to give radiation to young women. Treat patients with hormone therapy until the average age of menopause. And don't forget that this disorder has multiple organ effects. And I thank you very much.
Thank you. Amir.
Dr. Mazen Shikli, I have muted. Thank you very much, Wendy, for this magnificent lecture covering all the causes, management, and the new, novel techniques that might, bring some shadows and some hope to these ladies with the premature ovarian failure or premature ovarian insufficiency. One of the questions was addressing, do you think that a low AMH level in a young lady can give you that this lady is going to go for a premature ovarian failure?
Okay, so that's a great question. I think that the low AMH is more predictive of not being successful for ovarian stimulation, but actually it's not totally predictable of when a woman will become menopausal. It is of concern, however. So if you have a 32-year-old with a low AMH, I would speak to her and talk to her about what her reproductive plans are, and make a suggestion that it's possible that she may go through menopause a little earlier, but you really can't say when that's going to happen. So it's worth really talking to someone and counseling them, but it's not totally predictable.
Yeah, thank you. There are questions about stem cell therapy, which you already had addressed, and the PRP, which you already had addressed. Another question was, is continuous HRT better than sequential HRT for premature ovarian insufficiency?
Yeah, so I thank you very much for that question. And actually, we don't know. My own feeling is that it's probably better for women's breasts to have sequential therapy because you don't have the total exposure for the whole month. But we actually don't know. There's not a head-to-head trial. So certainly many women of this age take oral contraceptives with much higher doses of progestins. So if a patient doesn't want to menstruate, I don't have a problem with it. But I think optimal is still probably sequential. And many of our young women want to menstruate because they want to feel like they're friends, and also it makes them feel more feminine. But not everybody is like that. So it's individual.
Yeah, and there's a question about how do you investigate women with family history of premature ovarian insufficiency? Do you start by doing the chromosomal and then you go for the genetic testing, or how do you do it?
It depends what was found on the person who had premature ovarian insufficiency, but if someone just has a family history, you could at some point do an AMH, depending on what age the other person became menopausal. But I wouldn't do the complete assessment, and I wouldn't make them too worried yet. I know some people might do it at age 25, age 30, maybe every 4 or 5 years. But it's really, there's no guideline with respect to what to do about this. What would be nice is to have some sort of window in the future to know what each person's reproductive life is going to be like. If we somehow knew that, women could plan their life and not wait till they're 35, 36 until they try to conceive. Because I think there are many women who find themselves in this position of developing early menopause and they're totally shocked.
Yeah. One last question will be, at which age you would start to use testosterone in cases of premature ovarian failure?
So I don't use it routinely. I do a question about what the patient's sexual response is like, and many women they're not dissatisfied with their sexuality, and so I do not use testosterone routinely. If the patient is complaining on adequate estrogen replacement of low sexual desire, and we've looked at all the other biopsychological components of her sexual desire, and we make sure she has adequate vaginal moisture, then I would probably add testosterone. And I don't really think there's an age. It has been approved, as Nick said, for postmenopausal women. It's actually not approved it hasn't been shown to be effective in premenopausal women, but these women are postmenopausal, so they do require sometimes additional testosterone. But also the problem is that only about 30 to 40% of them will respond. Doesn't work for everybody. And we really do need a good testosterone for women. Using dosages for men in reduced fashion is not really totally acceptable.
Yeah, thank you very much. We have to stop at this question. We have plenty of questions for you, Wendy, but we don't have the time.
Okay.
So thank you very much. And now I'm going to give the Dr. Fakher to start the moderation for the next two speakers. Thank you very much.
You're welcome.
Thank you, Dr. عبير. الزميلات والزملاء الكرام، أحييكم أجمل تحية وأرجو لكم وقتا ممتعا ومفيدا في هذا اللقاء المفيد. Dear audience, our next local Jordanian speaker is Dr. Abir Ammar. She is Vice President of the Jordanian Menopause Society, Media Director of the Jordanian Society of Obstetricians and Gynecologists. Dr. Abir will talk about genitourinary syndrome of menopause. Please, Dr. Abir, you can start.
Thank you, Fakher. Okay, I'm going to put the full screen. My talking will be about the genitourinary syndrome of menopause. Genitourinary syndrome of menopause is defined as a collection of symptoms and signs associated with decrease in estrogen and other sex steroids, involving changes to the vulval area, vagina, labia majora, minora, urethra, and the bladder. And you can see the changes that happens comparing the healthy vagina with the atrophic vagina with the loss of estrogen. Pathophysiology is a result from a decline in serum estrogen, and it is the active form of estradiol that's really doing the whole function of the vagina, in which we lose after the menopause. And estrogen, I know, is the main one because it has receptors in the vagina, vulva, urethra, and fibrin of the bladder. And the vagina, just to remind you, has 4 layers: the stratified squamous epithelium, followed by the elastic lamina propria, and then we have the fibromuscular layer and the adventitia. And there is no mucus glands in the vagina. The secretions that comes in the vagina are part from the cervix and part from the transudation through the vagina. And this is a closer photo for the atrophic postmenopausal state in the vagina after the loss of estrogen. Now, what's the advantage of estrogen? It maintains the collagen content of the epithelium that affects the thickness and elasticity, and it maintains also the acid mucopolysaccharides and hyaluronic acid that keeps the epithelial surface moist. And it's very important also to optimize genital blood flow. The estrogen, so we got a non-keratinoid stratified squamous epithelium that will keep the vagina rugated and rich in glycogen. Glycogen from these slough cells, is the substrate for the lactobacilli that convert glucose to lactic acid. We have an acidic vagina. This will maintain the normal vaginal flora and protects from infection in the urinary tract and vaginal area as well. Menopause leads to a dramatic reduction in estrogen production. So serum estradiol level usually plateau at a level of 5 picogram per ml, but assay is not sufficiently sensitive to detect in postmenopausal ladies. So we don't use it as part of our routine clinical care. Changes develop dramatically, gradually over a period of years. It's not like the hot flushes, the insomnia, the cold sweats. It happens immediately in the perimenopause and after menopause. With the genitourinary tract, that happens, the changes happens over a period of years after menopause. And this hypoestrogenic status will include thinning of the top layer of the superficial epithelial cells. There will be loss of ruges, loss of elasticity, shortening and narrowing of the vaginal canal, and reduction in the vaginal secretions, and increase in the vaginal pH. And this can lead to trauma and bleeding while taking a pap smear or doing a sexual intercourse, and sometimes pressure ulceration. And this will make the vagina liable for more infection. And the low glycogen content will decrease the lactic acid. So there will be a change in the decrease in the lactobacilli and overgrowth in non-acidophilic coliforms. So more infection by skin and rectal flora like Streptococcus, Staphylococcus, and bacterial vaginosis and Trichomonas. So there's a change in the environment of the vagina. Urinary tract structures are derived from the same embryonic origin as the genital tract, and contains also an estrogenic receptors. So the changes will involve also the bladder, the urethra, the pelvic floor musculature, and endopelvic fascia. And all of these will be affected by the hypoestrogenic states. And these women will be having urinary symptoms. They will be having frequency, urgency, hematuria, dysuria, and increase in the urinary tract infection. Androgens as well, they play an important role in urogenital health through its receptors in the vagina. The prevalence of genital urinary symptom of menopause, it's not well established. International survey of over 4,000 menopausal women reported there's almost a 40% ladies chance had symptoms of vaginal discomfort. 50% reported the quality of life had been affected by the atrophy. As women are living longer after menopause, this problem will rise up more and more. Now, the etiology of the genital urinary syndrome of menopause, most of it is related to natural menopause, but you have to have other cases, to think of other cases that might have the genital urinary syndrome of menopause, like in cases of premature ovarian insufficiency, like when you talked about bilateral oophorectomy, for any reasons, for many reasons to discuss. Okay, primary ovarian insufficiency, ovarian failure due to radiation, chemotherapy, or uterine embolization could be also a cause. Premenopausal use of medications that has an anti-estrogenic effect, like the tamoxifen, aromatase inhibitors, danazole, and progesterone, and gonadotropin-releasing hormone agonists. So these patients also will suffer from these symptoms. Also, the postpartum lactational amenorrhea, they might come complaining of these symptoms. The hypothalamic amenorrhea or amenorrhea in severe SLE and rheumatoid arthritis combined with cortisone therapy. So combined suppression of ovarian and adrenal activity will make these ladies suffer. Cigarette smoking could be also a cause. Abstinence from sexual intercourse, vaginal nulliparity, and vaginal surgery and radiotherapy. Women with depression and urinary incontinence can have these symptoms as well. Clinical presentation, 70% of these, they don't discuss this condition with their doctor. They're ashamed. Okay, so some believe their symptoms are expected and it's just part of ongoing process. So cultural, religious, and social beliefs plays a role in making women feel uncomfortable discussing these concerns with their doctor, especially in our area. Rather than seeking treatments, they modify lifestyle changes to deal with their symptoms. They just stop having sex, not to have pain because of the vaginal dryness. So the symptoms usually is dryness, vaginal dryness, decreased lubrication. They might come with vaginal and vulval bleeding, decreased arousal, orgasm, or sexual desire because of the pain. They might having burning sensation, irritation, itching, discharge, and they might have recurrent UTI and dysuria and frequency. How do I evaluate my patients? I always start by taking a medical history, and I push my ladies to talk about these complaints. about these. I push them to complain. I push them to talk about these their symptoms. You should ask your patients about the symptoms, as usually patients, they don't share their symptoms with their doctors. They're ashamed of it. You have to go for a very gentle examination with the smallest speculum, and usually labs are not needed in such cases. And we have to look for signs of atrophy. You have to look for the resorption or fusion of the labia minora, the fragility, the introital retractions. You might have to look for the urethral eversion and prolapse. There might be pallor or erythema at the vagina and loss of the rugis, okay? So always check for these symptoms. And the differential diagnosis could be lichen sclerosis, lichen planus, genital ulcers from Crohn's disease, or it's due to trauma, infection, or malignancy, or it's dermatitis process. Management is guided by the patient's symptoms and goals. Ending the silent suffering is important. Start early treatment before severe atrophic changes supervene, affecting the relationship with her partner. Management always start by having the moisturizers and lubricants, and usually we use them as first-line treatment and usually for mild symptoms. And we use the vaginal moisturizers every 2 to 3 times per week for the dryness and coital comfort. We use the lubricants at the time of the intercourse, and they could be of different types: the water-based, the silicone-based, the oil-based. And now everybody is talking about hyaluronic acid as vaginal gel and suppository, with having a very good evidence of treating the vulvovaginal atrophy. Comparing results, which is better for relieving symptoms of vaginal dryness, is consistent. Some of the doctors say they are effective as estrogen, but others think no, estrogen is better. Now, estrogen is the mainstay of treatment of vulvovaginal atrophy that does not respond to moisturizers and lubricants. And sometimes, if it's severe, we have to combine the systemic and local estrogen that might be used together at the beginning if there are no contraindications for estrogen use. Estrogen therapy, it will restore all the changes that had took place. It will restore the pH. It will have a thickened epithelium, increase secretions, and decrease the dryness, and decrease the incidence of UTI and overactive bladder. Some adverse effects of these estrogens would be irritation, discharge, might have some bleeding, and breast tenderness. Serum absorption, there is lesser degree of absorption of estrogen therapy comparing to oral estrogen, and the plasma estradiol level is not sensitive enough to measure the low serum level of estradiol, so that's why we don't do it. And if we have to do it for any experimental, usually we use the mass spectrometry or ultrasensitive bioassays than the radioimmunoassay. Some studies reported systemic absorption is highest in the first days or weeks of therapy, and then they decrease with ongoing treatment. This could be because you're gonna start absorbing estrogen by a thin atrophic vaginal epithelium that will cornify with ongoing treatment. And some of the societies, like the North American Society, Menopause Society, they advise that you have an intercourse 12 hours after you have had used your local HRT or local estrogen, because you don't want the partner to absorb the estrogen, but this is not agreed upon by other doctors. They say they don't have a clinical significance, and you don't have to put a time limit when you use the local estrogen and you have your intercourse. Preparation of estrogen, we have the cream, we have the inserts, and we have the rings. All are similarly effective in relieving symptoms of estrogen atrophy. In the USA, we have the conjugated estrogen, the vaginal cream, and we have the estradiol for vaginal use as a cream, tablets, capsules, and ring. In Europe, we have the estriol cream, and in Jordan, we have vaginal tablets, estradiol, are available. Estrine vaginal cream is now available. And before COVID, DHEA vaginal inserts would have entered the Jordanian market. Now, the low-dose vaginal estrogen is defined as the one of having less than 50 microgram estradiol, or less than 0.5, 0.3 milligram of conjugated estrogen. And higher doses are associated with endometrial proliferation. Lowest concentration, we have 4 microgram and 10 milligram. What will give you to your treatment is the patient preference, شو بتحبي تستعمل, what does she like to use, convenience and cost, and the systemic absorption. Usually we advise for symptomatic vulvar atrophy with fissures to start with the creams. Once they heal, we can switch to vaginal inserts or ring for chronic use. The vaginal tablet, we have the 4 microgram and the 10 microgram dose. And usually dyspareunia is the first thing to improve in 2 weeks. Dryness will improve in 2 weeks with the 10 microgram, but it will take 6 weeks to improve with the 4 microgram dosage. And the irritation and the itching will improve in 10 weeks time of use with the 10 microgram vaginal tablet. Serum estrogen absorption, microgram did not show any difference in serum estradiol concentration. 10 microgram showed increase in concentration on day 1, but 0 on day 14. Then we have the estring, like a ring covered with estrogen. It releases 7.5 microgram of estradiol daily for 90 days. After which it's replaced by a new one. Serum estradiol level بكون لسه مقبول من 5 to 10 picogram per mil. We have the ring and we have the soft gels. هذول جداد نزلوا بأمريكا كمان. The creams, usually we use once daily for 14 days, then twice per week for 3 to 6 months, and then as needed. We have Primarine, and we have the estradiol and the estriol. No need for opposing progestin use to protect the endometrium. We don't use progesterone to protect the endometrium when you use the local estrogen for vulvovaginal atrophy. Now, few data are available for endometrial activity after vaginal estrogen use. No studies for more than 1 year has been done. And if you use the 10 microgram estradiol, 1 case of endometrioid adenocarcinoma in 386 women who used it for 1 year, but baseline study was inadequate for analysis. For the vaginal ring, no increase in endometrial thickness by ultrasound. And for the low-dose conjugated estrogen cream, in a study of 20 women, 1 case of endometrial hyperplasia after 6 months of use. Duration of treatment, it depends on the patient's symptoms. Usually there is improvement in symptoms in 2 to 4 weeks, and it can be used as needed indefinitely. Other options, so we said the moisturizers, the estrogen locally, then we have the dihydroepiandrosterone, the prosterone, 6.5 milligram vaginal inserts. Okay, and this is a third-line treatment. And mechanism of action is aromatization of androstenedione and testosterone to estrone and estradiol. And after 12 weeks of treatment, there was increase of baseline concentration of DHEA, testosterone, and estrone, but not in estradiol, but still in the average postmenopausal level. It got approval by the FDA in 2016, and it is very effective treatment, especially for pain and dyspareunia. And efficiency has not been compared with vaginal estrogen. So it will improve pain during intercourse, sexual satisfaction, and vaginal dryness. May have a role in patients who doesn't want to use estrogen therapy. Then we have the oral osmimefene. This is the only oral treatment that's used for local atrophy of the vagina. So it is a selective estrogen receptor modulator with estrogen agonist effect on the vagina, no clinical significant estrogenic effect on the endometrium or the breast. It has an FDA approval 2013 for moderate to severe vaginal atrophy. It's to be used in patients who can't introduce vaginal estrogen. They can't reach their vagina because of severe arthritis, because of morbid obesity or vulvodynia, or they just they don't want to put anything in their vagina. Then you might offer them this drug. Side effect: 7% complain of hot flushes. There's the potential for thrombosis, but no reported cases of DVT. Not safe with history of breast cancer and thromboembolism, but it got a neutral or inhibitory effect on carcinogenesis in the breast. It has a good potential effect in reducing bone turnover, no effect on endometrium. In studies done on its use for 1 year, there was an increase in endometrial thickness, but no hyperplasia or carcinoma. And there was no comparison studies with vaginal estrogen. Testosterone is a common reason to use in women with genitourinary symptom of menopause and low libido. Data support vaginal testosterone may stimulate vaginal mucosa and improve symptoms of dryness. There are androgen receptors in the vagina, and it will improve elasticity and dryness, but serum testosterone increased from 33 nanogram to 171. So safety in breast cancer is not established yet, and still we need more results for the vaginal use of testosterone. Laser and radiofrequency devices, still more RCTs needed. More than 30 papers are there, one RCT only. It's in the market since 2010. But there is an FDA warning about its use for vaginal atrophy or stress incontinence, and till now it's not approved for that use, although studies are going on and we're waiting for better results. So this is the vulva, this is the vagina after laser use. Others like vitamin D, oral vitamin D, vaginal vitamin E, oral and vaginal probiotics. No evidence. Evidence is there weak about its use and effectiveness. If after hormone treatment still she's in pain, you should think of a differential diagnosis of vulvodynia, myofascial pelvic pain syndrome, and interstitial cystitis. Vaginal dilators can be used with lubricants or local estrogen. And sometimes we might use them even the patient is not complaining. Prior to vaginal surgery, we are using it with a pessary for prolapse and urinary incontinence, or menopausal women that's going to get married for the first time. Now, for the patients with the breast cancer, with genitourinary syndrome of menopause, non-hormonal options are the first line treatment. Hadola, we don't like to give them hormone. Low-dose estrogen or progesterone, okay, DHEA, can be used only in cases of low risk of recurrence, okay, not aromatase inhibitors. The oncologist had approved you to use it, and informed consent of risks and benefits, because we don't know enough, has to be used. In premenopausal women taking tamoxifen, it has an anti-estrogenic effect on the vagina. In postmenopausal, it got a weak estrogenic effect. Always remember this. Some women treated with tamoxifen will experience urogenital atrophy, and you have to deal with these patients, giving them moisturizers and lubricants. We suggest not using vaginal estrogen, DHEA, testosterone for women, and aromatase inhibitors for breast cancers, because they have an increase in estradiol level, which might increase their recurrence. Very few studies available on use of local estrogen and breast cancer survivors, and not on aromatase inhibitors, showed no recurrence, but will be always reluctant to use them. These patients should be strictly followed along with their oncologist. So the take-home messages for my talk will be: genital urinary syndrome is defined clinical entity. First-line treatment is non-hormonal vaginal moisturizers and lubricants. Second-line treatment is estrogen if no contraindications. Early intervention is necessary. Local estrogen preparations are available as creams, rings, inserts. Other options, DHES and osmorphine, are there. Laser has been marketed, but safety and efficacy has to be followed. And for breast cancer survivors, the best option is the non-hormonal vaginal lubricants. And thank you very much.
Thank you, Abir.
Thank you very much, Dr. Abir. We will open the session for the questions. There is a question: can more frequent intercourse delay the vaginal atrophy?
Yeah, it can be used. Yeah, the husband can be used, along with lubricants. Okay, it can definitely. Frequent intercourse can help, especially if used with lubricants.
Next question: local estrogen, where they do affect either bladder or urethra. I think he's asking about the side effects.
No, if it's used in the vulva and the vagina, it will improve the symptoms and signs in the genital as well as in the urinary syndrome. So if you have the local, sometimes we use the estrogen for a recurrent UTI. Patient doesn't have a complaint, and then she comes with a recurrent UTI. And these patients, especially the elderly, I put them on a local estrogen, and they improve, and the recurrence of UTI will be less. So it's part of the treatment in elderly women with recurrent UTI.
One more question: for increasing libido, what's the best option?
Now, it depends. In the postmenopausal ladies, we are talking about transdermal testosterone. Now, the libido, it's something that you have to address, and you talk to the patients about her relation with her husband, if she's in harmony with him, if there are any interfering factors that make her lost her libido. And if you treat all of these symptoms and you don't have anything else to advise, then definitely using testosterone in the supraphysiological concentrations of the women will be advised in postmenopausal ladies, not the premenopausal ladies. But this is what Nick Banet was talking about. Suzanne Davis had done a great study about testosterone use in postmenopausal ladies with decreased libido, arousal, and orgasm. But this needs a proper evaluation, a complete evaluation. It's not only you just go on decreased libido and you use testosterone. You have to address the whole problem. You talk to her intimately, and you talk to her partner. You try to find the answers. Sometimes it is psychological. It's not pure loss of or decrease of testosterone. And then if you think that all of them are solved and only you want something to increase her libido, then definitely testosterone local used in 1/10 of the male dose. This is the female usually dose. 1/10 of the male dose needed is the woman's need, and it can be used 2 to 3 times per week, transdermal, as gel or cream.
Finally, I have one more question. For those ladies who cure from cancer, when they can start the treatment, especially for estrogen?
You mean breast cancer?
Yes.
Yeah, breast cancer survivors usually they are put on long-term management. Most of them, they will have the the aromatase inhibitors for 5 to 10 years, Some of them will have 5 years use of definitely this is within after 5 years. If they are on aromatase inhibitors, then it's after they finish the treatment. And there are some people who give them 5 years, some of them they take 7 years, and some of them they take a 10 years treatment. But they can use the local, lubricants, and they can use the moisturizers, they can use the hyaluronic acid. There are many studies about now the hyaluronic acid gels and suppositories as lubrication in cases of breast cancer. And we have it in Jordan. It's called the Brimino. We have the Brimino. It's hyaluronic acid. It can be used for lubrication, especially if the oncologist will say no to you. Don't use for her local estrogen. This is a breast cancer survivor. But usually, if they are estrogen progesterone receptor negative, then you might be able to use it earlier with the agreement of the oncologist.
Thank you very much, Dr. Adia.
You're welcome.
Thank you very much. Now, I don't know whether the next speaker is available.
Hi, Alia. Yeah.
Hi, how are you?
Hi, we've been waiting for you.
Yes, I've been on the call.
Okay.
Excellent presentations.
Thank you very much. Thank you.
Do you want me to go ahead and share my screen?
Yes, please.
Dear colleagues, I am delighted to welcome you all on behalf of the Jordanian Society of Obstetricians and Gynecologists, and on behalf of all of you, let me welcome our next guest speaker from Canada, Professor Alia Khan. Professor Alia Khan, who will talk about advances in diagnosis and management of osteoporosis. Prof. Khan is a Fellow of Royal College of Physicians of Canada, Fellow of American College of Physicians and Endocrinologists. Actually, she is Professor of Clinical Medicine Divisions, Endocrinology, Metabolism, and Geriatrics. She is Director Fellowship of Metabolic Disorders, Bone Disorders, and Calcium Disorders Clinic at McMaster University. Professor Khan, I am honored to introduce you to my distinguished audience. Please, the turn is yours.
Thank you so much. And it really is my pleasure to speak to you all about how to diagnose osteoporosis and treat it, and what's new in 2021. And I'm just going to advance the slides. So these are my disclosures. I have received research funding for the development of new molecules for the treatment of osteoporosis and parathyroid disease. So these are the learning objectives. How do we evaluate fracture risk? What are the benefits of therapy, and what are the risks of therapy? And I wanted to begin by saying that we're going to be talking about postmenopausal osteoporosis, because the talk for premenopausal women is a totally different talk. And in premenopausal women, women can develop osteoporosis in the premenopausal years. And the important points to evaluate in that situation is, are they estrogen replete, and what is their body mass index? Because those are the two most important parameters that determine the development of osteoporosis and bone strength. And then we would evaluate such women in more detail to ensure that there are no hormonal abnormalities that are contributing to declines in bone strength and bone remodeling and the repair process. And there may be genetic causes for osteoporosis to develop, like osteogenesis imperfecta or hypophosphatasia or abnormalities in phosphate metabolism. So the assessment of a young woman who has had a fragility fracture and has osteoporosis is very different to a postmenopausal female. And the most important factor is the gonadal status. So there are two ways that we diagnose osteoporosis. In a premenopausal female, we can only diagnose osteoporosis in the presence of a fragility fracture. But in a postmenopausal female, we diagnose osteoporosis if they've had a fragility fracture, and we can also use bone density assessment. So in a postmenopausal female, if they have a T-score of minus 2.5 or less at the lumbar spine or the femoral neck or the total hip or the 1/3 radial site, then we can say that they have osteoporosis. And they have to be postmenopausal. The age isn't so important. So if you have a 30-year-old woman who's had premature ovarian failure, but she's postmenopausal now, we can apply the WHO criteria with T-scores. And if she has a T-score of minus 2.5, we can say she has osteoporosis. But that same 35-year-old woman, if she's eugonadal and has regular periods, the same bone density, we cannot make the diagnosis of osteoporosis without her having had a fragility fracture. So this is a very, very important point. In postmenopausal women, we can use bone density assessment or fractures to make the diagnosis. In premenopausal women, we have to have a fragility fracture, and we don't base it purely on the bone density. This is what a normal bone looks like. This is what osteoporotic bone looks like. In the osteoporotic bone, we have fewer trabeculae. They're also not connected. We have cortical thinness, and there's cortical porosity. So there's holes in the bone. And this bone is obviously going to be more likely to fracture with a fall in comparison to this bone. So it's important that we use a tool when we evaluate fracture risk. And in the Middle East and in Jordan, you can certainly use the FRAX tool. And the FRAX tool, for us in Canada, the Canadian flag will come up. But for you in Jordan, you would be utilizing the database that has been established for your country. And you will enter the patient's age, their date of birth, the gender is important to enter, height and weight. Have they had a prior fracture? Because if someone has had a prior fracture, that's associated with further fractures. It's a sign that the microstructure is abnormal, and that patient is more likely to have further fractures. If their parent had a fracture of the hip, that's important. We enter yes or no. Are they smoking? It's current smoking, yes or no. Glucocorticoid use, 5 milligrams of prednisone for 3 months or longer. And it's yes or no. It's ever use versus never use. And rheumatoid arthritis, yes or no. Do they have it or do they not have it? Do they have other secondary causes of osteoporosis, like hyperthyroidism, hyperparathyroidism? Do they drink alcohol, 3 or more drinks a day? Yes or no? And what is the bone density? And you would select the DEXA machine. Was it a hologic or was it a lunar system? And you would enter the femoral neck BMD. Now, if your patient hasn't had a bone density assessment, you can also evaluate fracture risk without a BMD. Some people can't get to the DEXA lab. And you simply enter all the information that you have and you press calculate without the bone density. And that will give you the patient's fracture risk. And if we don't use BMD, we see that the area under the curve is a 0.81. That means the model is 81% effective in predicting who will have a hip fracture. So it's a very useful model with or without BMD. It's also important for us to ask about falls, because falls are an independent risk factor for fracture. And it's important for us to ask about fracture history. If your patient has had a vertebral fracture or a hip fracture or has had more than one fragility fracture, you don't even need to fill out the FRAX form. You know that that patient has a high fracture risk. And a high fracture risk means that the risk of a major osteoporotic fracture over the next 10 years is 20% or higher. And a major osteoporotic fracture is a fracture of the spine, the hip, the forearm, or the humerus. Those are major osteoporotic fracture sites. So when we evaluate our patient, we have to take a careful history. And I really, encourage gynecologists to get involved in bone health assessment, because right now there's a huge care gap. And only about 20% of people who have even had fragility fractures have their underlying bone health evaluated. And gonadal status is critical in determining peak bone mass and maintaining peak bone mass. And if a woman has premature menopause, then she's going to have early bone loss. And it's absolutely essential for gynecologists to be involved in skeletal health assessment. We need to review our patients' medications, and we need to also ask, in addition to a careful menstrual history, did they have diseases like anorexia nervosa, during which time they may have had bone loss? Were they on Depo-Provera for prolonged time periods? Were they on GnRH analogs for endometriosis? Because these drugs would have caused them to become hypogonadal. Because we need to understand, why does our patient have osteoporosis now at this point in their time, in their life cycle? What happened before? When did menarche occur? Were they eugonadal until they reached menopause? And we also need to ask about fracture history. Have they had fractures? The definition of a fragility fracture is a fracture that happens with a fall from standing height. Or if they're running down the stairs and they fall from the third step or lower, and they break something, that's a fragility fracture. Fracture sites that are not considered fragility are face, hands, feet, and ankles. Everything else is considered a fragility fracture. And even if you're doing a virtual assessment with the pandemic, we need to look at their spine. And so if they have dorsal kyphosis, we can arrange for spinal x-rays to be completed. And maybe they experience vertebral compression fractures, but we're not aware of them. Approximately 2/3 of vertebral compression fractures are silent. And then we need to email our patient a lab requisition, because they're absolutely important. It's absolutely critical that they do certain blood tests before we are able to confirm that they simply have postmenopausal osteoporosis. And we need to make sure that we've excluded other secondary causes for bone loss before confirming the diagnosis and confirming the management plan. So there's a differential diagnosis of osteoporosis, and the most important one is hypogonadism. Another important point to remember is that the DEXA equipment does not adjust for height. So in petite women, it will underestimate the bone density. And why is this important? Because if we have people who have, if we have women who have Turner syndrome, for example, these women are petite, and their bone density will be better than the DEXA machine would indicate, because it doesn't adjust for height. And so the vertebral body of a petite individual is shorter, but it's also not as deep. So when they lie down on the table and radiation is passed through their spine, and then we evaluate the radiation that is being emitted, we can see that, and it's also in grams per centimeter squared, as opposed to grams per centimeter cubed. It's an areal density as opposed to a volumetric density. And so it underestimates the true bone density in petite women. And by the same token, it overestimates the bone density in tall women. So we need to evaluate the gonadal function, as we've discussed. We also have to check calcium levels. And calcium is bound to albumin. Half of calcium circulates bound to protein. So we always have to do calcium corrected for albumin. And you can order that, or you can do the correction. And if you're measuring calcium in millimoles per liter, it's you take your calcium and you add 40 minus the albumin times 0.02 to get your corrected calcium. So everyone has to have a blood calcium check. Sometimes patients have hyperparathyroidism, and the parathyroid glands are overactive, and the high PTH causes bone resorption and shifts calcium from the bone into the blood. And if we confirm that they have a high blood calcium and a high PTH, then we have to remove the parathyroid glands. But if the gynecologist doesn't do the calcium test, then you won't discover the cause for the osteoporosis. And it's very important that some basic lab tests be done, put them on a lab requisition, and give it to all of your patients so that we don't miss an important cause for the osteoporosis. If your patient has hypercalcemia, you can send them to the endocrinologist for further evaluation. But don't diagnose osteoporosis without doing your blood tests, and never treat osteoporosis without doing your blood test. If your patient is hypercalcemic and you tell them, here, take 1 gram of calcium a day, that's going to shoot their calcium even higher. So absolutely critical to measure serum calcium corrected for albumin. We need to measure phosphate as well, because calcium and phosphate bind to the hydroxyapatite crystal to form the calcium hydroxyapatite crystal, which is essential for bone mineralization. So calcium corrected for albumin, phosphate. We need to know our patient's renal function. When we have impairment in renal function, then phosphate levels start to rise, and that can result in an increase in PTH release. And also, as patients develop renal impairment, the hydroxylation of vitamin D is impaired, and that can result in osteomalacia or impairment in the mineralization of the skeleton. And also, as the renal impairment progresses, the drugs that are cleared through the kidney will not be adequately cleared. So if you are planning to give your patient a bisphosphonate, but if their GFR is below 35 mils per minute, then the bisphosphonate is contraindicated. But you could give denosumab, for example, which is cleared through the reticuloendothelial system, and you can give that drug out to a GFR of 15 mils per minute. So we have to do calcium, corrected for albumin, phosphate. We need to know our patient's renal function. We need to know our patient's vitamin D. The vitamin D that we're going to measure is the 25-hydroxy vitamin D. That's the assay that everyone has to measure. And as Wendy mentioned, patients can be vitamin D deficient or insufficient. And it's important for us to make sure that their vitamin D levels are normal, because if they're vitamin D deficient, that means the vitamin D level is lower than 25 nanomoles per liter, they have osteomalacia. And a bisphosphonate could be further harmful because it can further impair the mineralization of the bone. And these people need vitamin D. They might have celiac disease. That's the reason why they're not absorbing their vitamin D. They might have short gut syndrome. They might have had bowel surgery or Crohn's disease, or they might be obese. And obese women and men also, what happens is that the vitamin D is sequestered by body fat. So the vitamin D is sitting in the body fat, and it's not available for use. So we need to measure vitamin D. The vitamin D that we're measuring is the 25-hydroxy vitamin D, not the 125 dihydroxy vitamin D assay. But we need to measure vitamin D levels, and we need to make sure that they're normal. And normal is 75 to 125 nanomoles per liter. Everyone needs to have thyroid function checked. So you need to do a TSH. Your patient might have hyperthyroidism as the cause for their osteoporosis. I was asked to see a 35-year-old woman this week, and she was running on the treadmill and she fell and fractured her hip. And she had florid Graves' disease. She had hyperthyroidism. So, if you don't evaluate thyroid function, then you miss the cause for their osteoporosis. Not everybody has postmenopausal osteoporosis. 1/3 of women will have another cause for their osteoporosis apart from estrogen deficiency. And that's a large number. So we need to evaluate thyroid function. Hypercortisolism, you will look at this if your patient has clinical features of hypercortisolism, and if they have supraclavicular fullness or a dorsal fat pad or central obesity or hypertension or plethora. But, if your patient isn't responding to therapy, then you can certainly check the 24-hour urine for free cortisol. But it's not one of the first tests that we would do. So you don't need to worry about that. If you're concerned, you can refer the patient to the endocrinologist for that. The other important point to remember is, but those are the basic tests. Always check the serum immunoelectrophoresis. So the key test to do, CBC, we don't want to miss a cancer, so the complete blood count, calcium, phosphate, vitamin D, PTH, thyroid function, creatinine, alkaline phosphatase, and serum immunoelectrophoresis. If you do that workup, that's a decent workup, and nobody will fault you for that. Look at the drugs that they've been on. GnRH analogs, as I've mentioned, Depo-Provera. These are important drugs because they can cause problems. If your patient has been on an estrogen-containing contraceptive, then we have no evidence to suggest that they would have a negative detrimental effect on their skeletal health. These are basically the summary. In men, we also evaluate gonadal function by measuring testosterone levels, but you don't need to worry about that being gynecologists. But you can certainly take a picture of that and just remove the testosterone levels. And if you have a premenopausal female, check FSH and estradiol levels on day 3 of the menstrual cycle. Now, it's important for us to know that estrogen maintains the balance between the osteoclast and the osteoblast. So in the presence of estrogen, rank ligand expression, rank ligand is a signaling protein that is released by osteoblasts and causes pre-osteoclasts to fuse and to become active osteoclasts, and then they start to resorb bone. But in the eugonadal female, osteoclast function is balanced by osteoblast function. So the resorption pits that are dug out from the bone are being refilled completely. And the amount of bone that is being removed is equal to the amount of bone that's laid down. Now, when a patient becomes estrogen deficient post-menopause, there's an increase in rank ligand expression, and that increases osteoclast activity. So in the postmenopausal female, we have deep resorption pits being dug out, and they're not being refilled by the osteoblast. And the trabeculae become thinner and thinner and thinner, and then they will snap. And that is associated with significant microarchitectural deterioration and an increase in the risk of fracture. And the cortical shell becomes thinner and thinner. It develops more holes. We get cortical porosity. And that person falls, they're going to break some bones. Could be vertebral fracture, could be hip fracture. Hip fractures, you're looking at 25% mortality after a hip fracture, and 25% institutionalization rate because patients may not be able to regain independent ambulation. And vertebral fractures are associated with dorsal kyphosis and lung defects, restrictive lung defects, and ongoing issues with morbidity and mortality. So our treatment of postmenopausal osteoporosis has focused on giving bisphosphonates, and this can be given orally in the form of alendronate or risedronate, or intravenously in the form of zoledronic acid. And the bisphosphonate gets buried into the skeleton, and then the osteoclast will ingest the bisphosphonate, and it inhibits the mevalonic acid pathway, and it prevents that osteoclast from forming its cytoskeleton, so the osteoclast dies. We can also give denosumab. Denosumab is a monoclonal antibody, and it binds to that excess rank ligand that is being released because our patient is estrogen deficient. And this is given subcutaneously, 60 milligrams sub-Q twice a year. And a very effective way of bringing that remodeling back down into the premenopausal levels. We can also give an anabolic agent. An anabolic agent works on the osteoblast and stimulates new bone formation. And a very important piece of new information is that estrogen is also not only an anti-resorptive agent because it decreases excess rank ligand expression, but it's also an anabolic agent because it inhibits sclerostin, and sclerostin is released by osteocytes, and it blocks the osteoblast's ability to form bone. And the reason why it's important for us to recognize that estrogen is not only an anti-resorptive agent, but is also an anabolic agent, it's because any woman who has premature ovarian failure, if we want to provide them with skeletal protection, and if they're under the age of 50, the first drug for skeletal health is estrogen. always estrogen. None of the other agents are going to be able to match estrogen for skeletal protection. And it's absolutely critical to offer a woman who has had a premature menopause, if she has osteoporosis, don't go with the other drugs. Give her back estrogen. Make sure she's estrogen replete, because not only are we preventing bone resorption, we're also allowing these osteoblasts to form new bone. Now, for the postmenopausal woman over the age of 50, if we want to give her an anabolic agent to stimulate new bone formation, we could give her PTH, which is teriparatide, or PTHRP, which is abaloparatide, or romosozumab, which is also now available. And romosozumab is an antibody to sclerostin, that signaling protein that blocks the ability of the osteoblast to lay down bone. Okay, so who do we treat? So we've diagnosed osteoporosis, we've excluded secondary causes of osteoporosis. Now we're going to say we want to start treatment. Who are we going to treat? We're going to treat the patient who has a high fracture risk. That's someone who has a fracture risk which is 20% or more for a major osteoporotic fracture over the next 10 years. We also treat people if they have osteoporosis and they have a moderate fracture risk, or if they're losing bone or they have drugs associated with bone loss, such as anticonvulsants or aromatase inhibitors, which are associated with significant bone loss. And even if they have osteopenia, we would intervene in those patients at an earlier fracture risk, even at a low fracture risk or a moderate fracture risk. And if someone already has had a fragility fracture, we want to give them an anabolic agent. An anabolic agent will rebuild the bone. And we could give them a drug such as teriparatide or romosozumab. If they can't take an anabolic agent, then we would give them denosumab, because head-to-head data has shown us that denosumab is more potent than the bisphosphonates in improving bone density and reducing bone remodeling, which are surrogates of fracture risk. It's important for us to make sure our patients are vitamin D replete, and these are some of the publications that we've put out in view of the importance of vitamin D in a pandemic. And in view of our time, I will just skip some of those slides. But teriparatide, the anabolic agent, it's given 20 micrograms sub-Q daily for 2 years, and it can reduce vertebral and non-vertebral fractures. The bisphosphonates, alendronate, risedronate, and zoledronate reduce vertebral and non-vertebral and hip fractures, and these drugs work for 5 years. Beyond 5 years, we don't have non-vertebral fracture data or hip fracture data. And we know that the risk of an atypical femoral fracture rises beyond 5 years. So we can use these drugs up to 5 years. What about denosumab? With denosumab, we have 10-year data showing us that it reduces the risk of vertebral and non-vertebral fracture. Denosumab is a monoclonal antibody, and we never stop the drug without replacing it with something else. Because if we stop the drug, rank ligand expression will go up, and our patient will have a decline in bone density, and they can have fractures. They can have vertebral fractures. They can have multiple fragility fractures. And romosozumab is a very powerful anabolic agent. It can result in dramatic rises in bone density within 1 year, which is equivalent to approximately 5 years of denosumab therapy. And as I've mentioned, denosumab is even more potent than the bisphosphonates. So the most powerful drug is romosozumab, and it can have an impact on reducing new vertebral fractures as early as month 6. And there are black box warnings that you do need to know about. The black box warning for teriparatide is that we don't give it to anyone who's had cancer or has had radiation or has a high blood calcium or a high PTH. Why? Because teriparatide is an anabolic agent. It results in increases in IGF-1 levels, and it could potentially cause these cancer cells to grow. So we don't give it to them. Anyone who's had cancer or radiation, we don't give it to them. No one has had osteosarcoma in humans, but in rat studies that were given 60 times the dose, there was an increase in osteosarcoma in rats. But don't give teriparatide to a patient who's had cancer. That's the black box warning. Romosozumab also has a black box warning. And the black box warning for romosozumab is that we don't give it to someone who's had a stroke or has had an MI, because the major adverse cardiovascular events in romosozumab compared to placebo were the same, but when romosozumab was compared to alendronate had many more fractures, but the major adverse cardiovascular events were 1.1%, whereas with romosozumab, it was 2%. So it's less than 1% difference, but if someone has had a stroke or an MI, we don't give them romosozumab. So I'd like to conclude by saying, we won't have time to go through that. The take-home message is we need to exclude secondary causes of bone loss, evaluate fracture risk in everyone, and treat based on fracture risk. If they have a high fracture risk, absolutely you have to treat them. If they have a high fracture risk, the drugs that I would use are teriparatide, romosozumab, or denosumab. If they have a moderate fracture risk, then I would give them a bisphosphonate. And after 5 years, you can stop the drug because bisphosphonates have long-term skeletal retention. And we call that giving them a drug holiday. Because the fracture risk isn't high, there's still small amounts of the bisphosphonate being released from the skeleton, and this can provide ongoing skeletal protection. And it's in their best interest to continue to be followed. We want to make sure that our patients are taking a calcium-enriched diet and that they have adequate vitamin D. And if after 5 years we give them the drug holiday, we should do their bone density every 2 to 3 years and make sure that they are stable. Any patient on an anti-resorptive agent, whether it's a bisphosphonate or denosumab, should be asked about thigh pain or groin pain. Thigh pain or groin pain, because there's a rare side effect of anti-resorptive therapy, and the rare side effect is atypical femoral fractures. So there may be suppression of the osteoclast to such a degree that micro damage isn't being repaired. And these patients can go on to develop a thigh bone fracture, a femoral shaft fracture. We don't see these with estrogen because estrogen has anabolic effects. How commonly do we see atypical femoral fractures? Well, it's 1 in 1,000 with 10 years of bisphosphonate use, 1 in 3,000 with 10 years of denosumab use. Denosumab may not be as closely associated with an atypical femoral fracture, but ask everyone about thigh pain or groin pain, and if it's present, do full femur bilateral, full femur x-rays to exclude an atypical femoral fracture. So with that, I'd like to thank you for your attention and answer any questions that you have.
Thank you.
Thank you very much, Dr. Khan, for this very rich lecture and fruitful. And we have few questions, please, for our audience. For how long we can give bisphosphonate for? Yes.
Right, that's a very good question. So bisphosphonate can be used ideally up to 5 years. After 5 years, if that patient still has a high fracture risk, or they had a moderate fracture risk and they still now have a high fracture risk, we could switch them to denosumab or teriparatide or romosozumab, because ongoing bisphosphonate therapy has not shown reductions in non-vertebral fracture or hip fracture risk. If at 5 years their fracture risk is moderate, we can stop their bisphosphonate and tell them the drug that you took, it's still in your bones, and small amounts will continue to be released, and they will continue to protect the skeleton and inhibit the excess osteoclast activity. And that's the drug holiday, and we would watch them.
Thank you. What's the importance of Z-score of DICSA in the diagnosis of osteoporosis?
It's a very good question. So the T-score compares our patient to the young adult normal reference population. The Z score compares our patient to the age-matched peers. So a 35-year-old woman, a Z score would be looking at her bone density and comparing it to the normal 35-year-old female population. And we use Z scores in women who are premenopausal. And in premenopausal women, we look at Z scores, and if the Z score is up to -2, we say that's normal. If it's -2 or lower, we say that their bone density is lower than expected for age. But we never diagnose them as having osteoporosis just on the basis of the bone density. They have to have a fragility fracture. In postmenopausal women, we compare our patient to the young adult reference range. And if they have a T-score of -2.5 or less, we can make the diagnosis of osteoporosis even without a fragility fracture.
Yes, thank you. Another question, DIXA screening for osteoporosis in healthy postmenopausal women, how frequently should be used?
So if the patient is a healthy postmenopausal female, then they can go ahead and have a bone density test done if they have risk factors for fracture. And then if we're going to start them on if it was normal, they don't need to have another bone density for 5 years. If they have osteoporosis, we're going to start them on therapy. We can repeat the bone density, possibly in 2 years.
Thank you. Another question, what are good exercises for osteoporosis?
The best exercise for osteoporosis is walking. We talk about weight-bearing exercise, and we tell our patients I tell my patients walk 5 miles a day. That's what I tell my patients.
There are a lot of thanks to you from the audience on the full lecture, and really they are grateful thanking you. Finally, we thank Professor Khan for this nice and fruitful lecture.
Fakir, can I have a question, please, for Dr. Alia?
Yeah, sure.
Alia, do you use the TPS in your measurement? You said the fracs and the DS, and we're now using the TPS here in Jordan.
Excellent. You guys are doing amazing. And the TPS is a very useful tool because it enables us to assess bone quality. And we can add it to the fracs information, and it enables us to more effectively predict fracture because it looks at the microstructure at the spine. And it's like flying over a forest. It tells you about the clearing in the forest. If you have large areas where you don't have sufficient trabeculae, that will be associated with a higher risk of fracture. And the bone density may not reflect that. That's an excellent question. And using TBS is very useful in people who have diseases that affect bone quality, like poorly controlled diabetes and chronic kidney disease.
Yes, thank you very much. That was an excellent lecture, Alia. That was one of the best I have heard about osteoporosis. Thank you very much.
Thank you. It's my pleasure. Thank you so much.
Thank you very much. At the end, we're gonna give hugs and thanks to all our speakers that had shared our webinar for today, and we're looking to meet you all in person, and hopefully shortly. And I'm going to invite you all to attend our next webinar, which will be on the 18th of June, 2021 at Friday, 7 p.m. And it will be addressing urogynecology. Thank you all. Thank you, and good night for everybody.
Thank you, Amir. Thank you, everyone.
Bye-bye.
Good night. Bye-bye.
Bye-bye. Thanks for everyone.
Can we leave, Abia?
بحكي لابراهيم انت عم بتخرج الاسماء مش
الظاهر بيعمل withdraw ولا
ترى هيهم بيطلعوا واحد واحد.
انا
اوكي
شايف
تمام
الارقام عم تنزل. يس
تمام اوكي thank you very much فاخر. it was very nice بصراحة lectures excellent lectures. ال POF premature ovarian failure والاوستيوبروسيس was excellent. هاي excellent speaker أنا لقيتها عليها.
طبعا. هي اصلا ميديسن بتعطي، بس الاكسبيرينس اللي عندها واسعه صحيح.
yes yes
يعني
excellent
بالاناليسيس بالفيلد
yeah
مانجمنت والانفستيجيشن.
yeah so thank you very much and I will say good night. Thank
اوكي،
you
جود نايت
فاخر.
باي.
thank you
يعطيكم العافية.
إبراهيم.
يعطيكم العافية.
باي باي good night my dear. إبراهيم بس والله بدي أغلبك التسجيل ضروري مشان نحطه على ويب سايت الجمعية.
على طول بكرة الصبح إن شاء الله. توكل على الله.
وإبراهيم كمان والشهادات بليز كمان الشهادات الحضور بدهم شهادات بليز لو بدي أغلبك. أوكي
تمام
yeah.
ابراهيم كل شيء مسجل عندك ها؟
إن شاء الله إن شاء الله.
اوكي، ابعث لنا اياه بالايميل
بإذن الله.
شكرا يا
يا
إبراهيم.
حبيبي، على ايميل ابعث لي اياه، بكون شاكر لك
إن شاء الله.
شكرا لك.
تصبحوا على خير.
باي باي.
باي.